thinking. So if you want to go back to the mental status exam for just a second, abstract thinking is when you ask a proverb and you ask them to interpret a proverb. It's either can be concrete or, I guess, not concrete, right? So, for example, I was about to ask him a proverb. What did he do? He made up one of his own for me that about a particular type of cough drops. Didn't I know Hall's cough drops did it and Vickers doesn't? Wow, did not know that. But a typical proverb is something like this. Can you tell me what a rolling stone gathers no moss mean?
I don't know.
Okay. See, that's what it is. You know, you ask a person to interpret what it means to them. Okay? Let's try one more, just for fun, and we'll get on. Everybody's going, oh no, let me hide. Let me hide. Let's try this one. Okay. Let's try. He's looking down on his laptop. I got it. All right, here's your proverb. When a dragon enters the lake, even the little fishies can bite its tail.
Wait. I have no idea.
He has no idea. So those are things you think about on a proverb, right? But it gives you some conceptual thinking, right? Okay. The little fishies bite the dragon's tail, and the dragon can't do anything about it, right?
That's what it means.
Well, because you're so tiny, how can the dragon catch the thing?
But what would my response be?
You can say anything you want. That's the best part. Does it make sense? What your response is?
Oh, it makes sense.
Yeah, your response makes sense. There you go. Okay? Now, all the things you just learned for people who want to go out on the first date is not a bad tool to do. All right. Okay, so now let's go on to schizophrenia and other psychosis in the chapter on antipsychotics, okay? All right. Oh, here. I think I've got the iClicker thing working. So for this session, we're going to go through the first 3 items. The rest of the learning objectives will be covered on Friday. But for today's session, we're going to talk about the DSM-5 criteria for the various psychotic disorders. We're going to look at the multiple neurotransmitter function likely associated, that most of the evidence exists for schizophrenia and psychosis. And then we'll talk about the clinical presentation and talk about the positive, negative, and the cognitive symptoms that was one seen with patients with schizophrenia. And then, of course, when we start about therapeutics, we'll use how these antipsychotic drugs are utilized from an acute stage when they're acutely psychotic, when patients become more stable, and then, of course, for long-term treatment. We're going to talk about long-acting injections as well. We have preparations now that you give a single injection. It'll last 3 months. They are working on injections that'll last for 6 months, that kind of thing. Okay? They're even working in implantable things underneath the skin for drugs to deliver for 6 months, all that sort of thing. Talking about resistant therapy, we'll talk about kinetics, of course. And then really the last couple hour and a half or so on Friday, we'll look a lot about side effects because, you know, you think about the bar that these antipsychotic drugs have to reach, then all of a sudden they got a lot of side effects. And then you wonder why a patient with schizophrenia who has a judgment and insight problem anyway, they have these side effects and you really wonder why they don't take their drug, right? Of course they don't want to take their drugs because they don't like the side effects too. Okay, those are the things to think about. Okay, so let's talk about the various criteria that DSM-5 has for psychosis. One of the important things that you could tell as we go through these various disorders is their time factor, keeping in mind the time factors. That's why I put it in bold. So, brief psychotic disorder. Person has had at least one of these symptoms as listed above, okay? And it can be greater for 1 day but less than 1 month, okay? Greater than 1 day or less than 1 month. If it's less than a day, people start thinking about delirium, okay? Because, you know, that's something that could go away in a day, that sort of thing, and could be due to medications or whatever. But if it lasts longer than a day and less than a month, it's brief psychotic disorder. DSM-5 also has delusional disorder, meaning that there's no functional impairment. The person is just strictly delusional. It could be 1 month or longer. Give you an example. I had a patient in clinic who kept thinking he had an odor on his body that he could smell. I couldn't smell it, but I didn't really want to smell very much, but But he would take 4 to 6 baths per day. And that was his only delusion, taking 4 to 6 baths per day. And I asked him, well, what did you do when you went to work? He said he took an hour lunch in the time he'd go home and take a bath, then come back to work. Oh, come back after work, take another bath. Eat dinner, take a bath before going to sleep. Get up in the morning, first bath. Wow, okay. But everything else fine. Had a job, didn't hear voices, didn't any of that sort of thing. Knew where he was, what he was doing. Good auto mechanic. He was fixing my car. So, those are things to think about. So, you have delusional disorder. Just about one thing. Okay, there you go. All right, schizophreniform. You can see now we're getting a little more serious, meaning that you're forming schizophrenia, because you won't find this word in the Webster's dictionary. You have to at least have 1, 2, or 3. Okay, it's criteria A. Disorganized or catatonic behavior. Catatonic is exactly what it sounds like. Person just shuts down in their own little world. Okay? Disorganized meaning that they're just so out of it, they can't make sense of their lives. Okay, in that aspect. You can see the duration is at least 1 month, but less than 6 months. 1 month, at least 1 month, but less than 6 months. Okay? And then that's when we get to schizophrenia. Can you see your symptoms are basically the same, but it's a continuous disturbance for at least 6 months. So a person has to work their way up through the chain from brief what? Psychotic disorder to schizophreniform to schizophrenia based upon time. Okay? When we say continuous, it's typically more days than not of the week. And if you're looking at a number, it's typically at least 3 to 4 of the 7 days of the week, continuously. Because some days they just may be okay for that time period. But you're looking at the entire broad picture of the disease. Okay? The lifetime prevalence, depending on which study, always hovers around 1.1%. The onset, and this is worldwide, doesn't matter where you are in the world. Okay? China, Russia, wherever. Europe, Australia. Interesting how consistent that is. The onset typically is in late adolescence, early adulthood, males and females, 15 to 29. I have a nice picture that shows you that. Rarely past 50. That's very interesting to see that. And slightly more common in males than females, and then a disproportionate higher rate amongst African Americans and non-Hispanic whites. So it's very interesting to see that. But again, to me, from your textbook, that's typical USA textbook. I've done some work in China and Taiwan, and they have the same incidence of schizophrenia, that kind of stuff, as we do. So let's try this one. First question, test the system. The duration of symptoms must be at least 6 months as a criteria for schizophreniform. I know, got to get the cobwebs out. It's Wednesday. All right, we're going to stop at 45 seconds. Oh, I like that. Zzz. All right, 85% false is the correct answer. Continuous 6 months is schizophrenia. Less than 6 months is schizophreniform, or greater than a month. Again, so know those particular time frames under diagnostic criteria. Because you'll see it again. All right, so this is age of onset that's been studied and reported in the literature. You You can see here males, females, and we said you could see rarely past age 50 in this aspect. So when you think about that, looking at this age frame period, you're seeing around 15-ish is when, where are they in school? High school, yeah. So when persons are starting to have difficulty in their studies, when they first were like straight A students, all of a sudden they kind of lose it in their grades. Those are things, they need to start thinking about some evaluations, not just for schizophrenia, but other potential problems, which we'll talk about. Okay, but certainly this is, you can see the peak incidence in this aspect. Okay, so now, where does it come from? That's a great question. It's a combination of a lot of factors. And so when you think about it, yes, it's genetic in this aspect, okay? It runs higher in families. It can run even amongst brothers in the same generation. They've done twin studies. Twins could have them, okay? You can see early part of my career, I was down in San Antonio. We had twin brothers, and their mother did a horrible thing, and we admitted patients based on geographic regions to units. So one unit had, patients from whatever county, that kind of thing. Well, we had twin brothers, and their mothers named them both the same first name. Daniel Douglas. They had different middle initials. There was a med error literally every other day on them because the other person would get the other person's med. Huh? What? I don't know. Michael Jackson named both his kids the same name? I have no idea. He did? Well, okay. Oh, that's fine. But if something like that happens, what we did, we split up the brothers into different units. So, those are the things you have to think about, okay? Because I can tell you no one wants to take another person's antipsychotic drug. All right. There are environmental factors, and we'll talk about some of those aspects. So really, if you think about it, genetics, molecular aspects, and environmental are certainly part of that. When we talk about pathophysiology, we'll talk more about that. Obviously, something's going on in the brain. When we look at that from transmission, neurodegeneration, we talk about that cognitive impairment aspects. And then all that translates to what you see clinically from impairment in memory. You have those positive symptoms, which we'll talk about, like hallucinations, delusions, and then some other negative symptoms like alogia and anhedonia, giving you that overall picture of what you see in a patient. As mentioned, there are some genetic factors, and there seems to be a higher risk, of course, in first-degree relatives, but is a tremendous increase, like tenfold, if your parent or sibling has the condition. So keeping in mind all that aspect. And then if both parents, can you imagine two schizophrenic patients marrying and having a family? That happens, okay? And so the child has a 40% chance, and then, of course, you can see twins really quite genetically related. There have been some neurodevelopmental models, but we don't really know. But some people think there's certain viruses that cause it. Well, we just don't know that as well. But certainly, people can hypothesize that. The first inkling of schizophrenia and psychosis, at least relating to dopamine, came from the amphetamine model. Because when we knew that people overdosed on amphetamines or took high doses of amphetamines, they became psychotic. And said, must be something with dopamine. And this was like in the 60s, and that's when we started looking at that particular neurotransmitter and, of course, the development of antipsychotic drugs. And then, of course, the cognitive impairment. As you mentioned, early in high school, the grades start going down, that sort of thing. All that starts to take place. And actually, in the olden days, schizophrenia, we're talking like the 1890s when they recognized these mental disorders. The original name of schizophrenia was dementia precox, from the cognitive impairment seen at such an early age. They didn't call it schizophrenia in those days. They called it dementia precox. Very interesting aspect. It's fascinating to read those literature. Okay, these are some of the genes that have been identified with schizophrenia, just to let you know. And then there's, of course, some of the potential effect on neural transmitters in this aspect. So when you look at the model, I